Evening. Welcome, everyone. Thank you for joining us for our monthly Mastery webinar series, where we will discuss the Lapiplasty, Adductoplasty, SpeedMTP systems, and expand beyond those, all really focusing on these core procedures for comprehensive 3D foot, midfoot, and forefoot correction. If you have not joined one of our webinars before, a few housekeeping logistics items. All attendees are automatically placed on mute when joining, but we really enjoy and encourage these to be interactive. So at the panel to the right of your screen, there's an area where you can type in questions or comments. Please feel free to do that. We'll be monitoring and discussing them as we go. And then we'll have some time at the end as well for any that we didn't get to or for some extra questions at the very end. And without further ado, I would like to introduce our esteemed faculty. It is my greatest pleasure to introduce these gentlemen here. We have Will DeCarbo out of Pittsburgh, Pennsylvania, Jody McAleer out of Jefferson City, Missouri, or Missouri, as Dr. Smith said earlier, and Dr. Bret Smith out of Orlando, Florida. Gentlemen, welcome. Thank you for being here and looking forward to a great event.
Hey, Lauren, thanks.
Thank you. All right.
DeCarbo, are you with us?
Get rolling there,
Yeah,
DeCarbo.
so thanks guys for being here. We want to celebrate National Bunion Day. This was actually the brainchild of Dr. Jody McAleer. Jody, you want to talk about how this came about?
Yeah, long story short, we originally established the first Bunion Day through the mayor of Jefferson City, Mayor Kerry Turgan, gave us a date on the calendar through the city council, and then subsequently, years later, our previous governor, Parsons, gave us a letter of recognition for bringing Lapiplasty to the state as the first facility in Missouri to perform the procedure. And then fast forward one more time, and our current governor, Governor Mike Kehoe, gave us an actual day for Lapiplasty, a National Bunion Day in Jefferson City and in America and in Missouri. So that's today.
That's been awesome. The idea of this is for foot health awareness and bunion awareness. And what Treace really has done is change the perspective of bunion surgery. And we hope to share some of that with you all tonight.
So is Missouri in the United States? Huh.
Technically it is, technically.
Okay, technically, got it. All right.
Yeah, we're kind of in the middle-ish. Yeah. You may notice us when you are flying to like New York or LA. You'll kind of see us. We're right below you, halfway through the flight.
With the big lake?
Pretty much.
So we all are all paid surgeons. These are our opinions that you will hear tonight. So this is just the agenda. We're going to go through the evolution of bunion and how we have adapted that for midfoot correction, different algorithms for treatment, and we'll go over surgical pearls for case points. So this is really our first slide. Bret, you were part of this original team, the picture kind of in the top right-hand side there. What was the issue with bunions, and then how did you come about the Treace concepts and the Lapiplasty?
Yeah, so this picture is actually the very first meeting in the East Memphis Marriott, second floor conference room. And so John had called a few of us, and he'd kind of tasked us with an idea of come down, let's talk about a foot and ankle company. And I didn't know who was going to be there. And he said, bring 5 topics that you hate about foot and ankle. So I show up. I knew Bob Sandtrock. I knew Scott Ellis. I didn't know Paul or Dan at the time. And we all presented, and every single one of us, we all had different topics, but every one of us had hallux valgus or bunions. And we realized, okay, there's a concept here. And we all had some different ideas. And that's how it sort of started. It was in a conference room with some pieces of paper and some pens, kind of drawing down some ideas.
Yeah, that's awesome. And that has grown into, 11 years plus later in the Lapiplasty, and it's the company procedures we'll talk about. So we can go to the next slide. So Jody, talk to us about this, the thesis of Bunion and the triplane correction and kind of the aha moment with the video at the top.
Yeah, so I think mainly what most of us seen traditionally with our bunion surgeries is that, you know, there's been really lackluster results, you know, so we've all been trained in different ways, different methods, different osteotomy approaches, but what we've seen is that there's something missing from the outcome, right? So we have issues with reoccurrence, undercorrection, patient dissatisfaction. So what we discovered was a large component that was missing, especially at the kind of the precipice of this kind of aha moment, like Will was alluding to, was we're missing the third plane of correction, which is the frontal plane. So that rotational component of that metatarsal, we were missing that. And so when we're correcting these things, in large part, we're correcting the transverse plane, leaving the patients largely undercorrected. And then Paul Dayton showed us through a lot of his work that he's done, this idea of being able to manipulate the metatarsal in all three planes to drive the metatarsal back into alignment rather than changing the anatomy of the metatarsal. So it's an alignment, a realignment, a correction without a cut and creating a new deformity in the bone. And so that's what this video represents right here. So bringing these sesamoids back, making that first MTP congruous, and aligning that first metatarsal and second metatarsal together parallel to one another. And that's what a lot of us were missing.
Yeah, that's really the key, and that was the springboard into everything that we've created since. We can go to the next slide. So Bret, you know, a lot of talk has been said about the instrumented procedure and reproducible and do people need it and this sort of thing. You know, talk to us about that. In most orthopedics, total joints, you know, it'd be unheard of to do a surgery without guides and alignment jigs and whatnot for efficiency. Talk to us about why the perception is we don't need this with midfoot, forefoot surgery.
Yeah, it's always confused me because for me, it was like, why wouldn't I? Like, I wouldn't do a total ankle freehand anymore. Now, granted, yeah, when we started off a long time ago, they were more freehand. I mean, I remember my total knee training, you know, my mentor, he used a very simple cut guide. It was, you know, not freehand, but it was pretty simplistic. But nowadays, I mean, these guys are using robots to do their knees, right? I mean, you know, so much more precision, and there's no difference in doing a total ankle in precision. So why wouldn't I use it for my other deformity, which is midfoot deformity? So if I can do something that's predictable, reproducible, and now with PSI, I can pre-plan what my correction will be. Why wouldn't I want to do those things? I get it. Folks are great surgeons. You don't necessarily need them, but why wouldn't you want to use them if it makes it easier, more predictable, and efficient? To me, it just makes sense. I mean, I want to do everything I can to help my patient get through the surgery as quickly and efficiently as possible and have the best outcome.
Yeah, awesome. And you know what's interesting, Jody, just talk about a couple of these points: the early protected weight bearing, the shortening of the bone. You know, those are all problems that we dealt with early on, and we ended up publishing on them to prove that they weren't an issue. Can you just talk about that for a second?
Yeah, I mean, one of the main things, right, that patients would do after, you know, a Lapidus procedure is they would be in a cast, completely non-weight bearing, maybe 6 weeks, 8 weeks. And the thought process was, you know, these constructs that are being placed at the first TMT are not stable enough to be able to facilitate weight bearing. But with Lapiplasty, with the concept of biplanar plating, what we find is not only can we maintain correction, but it will support immediate weight bearing, and it actually helps to benefit some secondary bone healing processes and fusion, facilitate fusion at the TMT. So you get the best of both worlds, and the patients get the functionality of maintaining some weight bearing, some freedom, which actually really helps them from a mental perspective, as they don't have to deal with all the difficulties of just completely keeping that foot floating off the ground for, you know, several months at a time. So we published through the Align 3D study, and we're working on our 5-year publication right now, that we have really kind of put all of those concerns to bed. And again, it goes back to what you guys were just talking about, is the instrumented nature of the procedure helps to facilitate the process, almost like minimize shortening to the point where we're just getting into the subcondylar We're getting past the subchondral plate, getting into the medullary canal to facilitate adequate bone-to-bone contact for healing, which you have to do. You really need to do that. It's imperative. So it's been, it kind of answers all the concerns that the literature points to when it comes to the Lapidus.
Yeah, and what's interesting, we'll talk about this when we get into our biplanar plating, which is next, which is a perfect segue to this. And that is really why we were able to do immediate protected weight bearing as opposed to with the tarsal metatarsal fusion, like the traditional Lapidus, like you were talking about, your non-weight bearing, 4, 6, 8 weeks. Bret, talk to us about this biplanar plating. What is unique about this? What did this allow us to do from a fixation standpoint?
So with biplanar plating, what you're essentially doing is kind of the idea of like an internal external fixator, right? So you're allowing for micromotion, secondary bone healing, which is natural bone healing, callus formation, and which is the fastest and most stable form of bone healing. It's what our body does naturally to heal bone and has done for millennia. And so what we're doing is we're simply allowing for that to occur in a very predictable, stable fashion. So what we did early on is, and I credit Treace to some degree with this, but also I think probably our neurosis as the early SAB on this was sort of saying we need to know. We need to have mechanical testing. We need to see what the micromotion is. We need to see what the failure rates of these biplanar plates are. So we did all those studies. We looked at a traditional 4-hole Lapidus plate with locking screws and a 4-0 crossing screw compared to the biplanar plates, which looked at the time very, very small compared to what most people were using. And we found that they were vastly superior in both load to failure and cycle to failure. And since that time, every time we iterate a new version of a system, we go back and we do those same testings and compare it to what is essentially our early benchmark and make sure it's at least as good. And I will tell you that ever since we've done this, every iteration has been superior to the ones we've done before in terms of its reliability. So we get a little neurotic about testing all this stuff. So
awesome. So we'll go to the next. So really what we think that we're seeing on radiographs is not 100% true. When we talk about the intermetatarsal angle, hallux valgus, tibial sesamoid position, medial eminence, pasa, dosa. Jody, you had talked about the triplane correction in the video. What happens when you anatomically align that first metatarsal?
Yeah, what you really quickly realize is all of those things that we're looking at are artifacts. They're radiographic artifacts based upon the projection angle in reference to the position of the first metatarsal. So as that metatarsal comes back into alignment, most of these things that we're taking as true measurements, they're really not there once the alignment occurs.
Awesome. Next slide. So Jody, this is a case of yours, and this kind of dovetails into the importance and the development of metatarsal adductus. So we proved bunions in isolation are a triplane pathology, and we need a triplane 3-dimensional procedure, and hence Lapiplasty was born. We did biplanar plating for immediate protected weight bearing, but there's a subset of patients where even with a 0 intermetatarsal angle, they still have tibial deviation of the lesser toes. Talk about this, and that will get us into the next slides about metatarsal adductus.
Yeah, so this is a budding floor nurse just coming out of nursing school who came to see us years ago, and she said, listen, I had Lapiplasty and I'm unhappy. She said, if you look at my non-surgical foot and if you look at my surgical foot, I still basically have the same deformity. She also wasn't happy with the aggressive tissue handling and the scar, so there's another issue there as well for her from a cosmetic perspective. But she was still having pain at the great toe. So when you look at the job that was performed by the surgeon that did Lapiplasty, they did a good Lapiplasty in isolation. The joint is nearly congruous. The sesamoids look like they're kind of back. The first and second metatarsals are aligned. But what you don't really fully appreciate is the true intermetatarsal angle is much larger than what the measured intermetatarsal angle shows. And that means that the second metatarsal is deviated towards the midline of the body. So we have a degree of Metatarsus adductus. So they have an elevation in Serrato's angle and Engel's angle. their angle is off, which kind of hides the degree of the deformity that's present. And when you correct the first metatarsal to a pathologic second metatarsal position, you end up with an undercorrection. So the patient ultimately was unhappy because they needed their adductus corrected. And that was something that initially when we first started doing these, we weren't quite sure if we could do consistently, if we could instrument, again, because of the three-dimensional nature of multiple bones, multiple planes. But as we started trying and learning, we actually discovered it in many cases is the easiest part of the case.
Yeah, and as this shows, 30% of patients that present with a bunion have metatarsal adductus. So, you know, we do these educational events all over the country, been doing it for well over a decade. And one of the things that we say, if you're not doing metatarsal adductus surgery, you're missing this 30% of the time statistically. We can go to the next slide.
You know, if you think in medicine, you know, we quote numbers all the time. I mean, 30%, that's a pretty significant number to not be thinking about, right? So it's not like, you know, 1%, too. It's 30%. That's a third. That's a lot.
Yeah, no, 100%. So, Jody, one of the main things that we came up with in regards to metatarsal adductus alignment is the plumb line. And we published on it. We presented on it in posters. Can you just go through this concept? If you understand this concept, you understand a concept of metatarsal adductus and when a patient may need that corrected.
Yeah, so the reason we came up with this method is, and we also worked to verify the method as well, is because often we found that Serralato's angle, Engel's angle, Kilmartin's angle, these various descriptors that are in the literature, they're not really verified. So they're kind of these legacy measurement techniques that have been around forever that we use, but we don't quite always understand what the numbers mean. And it does not provide us with any algorithmic approach in making a decision whether or not the patient has a condition and whether or not they may benefit from a surgery to correct that condition. So what we wanted to do is kind of have a no-go or go or no-go zone or line that would kind of divide literally the patients that needed adductus correction versus those that did not need it or would potentially benefit from it. So what we did with this is we isolated the medial cuneiform axis, which is a fairly consistent 2-point measurement, where you just take the base of the first TMT, and then you also have a secondary point at the navicular cuneiform joint. We take a third point at that lateral aspect of the first TMT, and we just basically shift that line in a parallel fashion over. We subtend the line, and then we look to see if the the first metatarsal can be corrected to that line without intersecting the second metatarsal. Just want to basically see if there's enough room to put the first back to its anatomic position with correction of the first ring in isolation via Lapiplasty. And in contrast, you can see the image on the right where that same line is being drawn on the medial aspect, being transferred over to the lateral aspect of the TMT subtended, and you can see how that second metatarsal is just physically in the way of our ability to put the first back to its home. So therefore, that tells us that we need to get 2 and 3 back into position first, and then we can come and do the finalized correction, giving us the option to do a better Lapiplasty, essentially, by getting the lesser metatarsals put back out of the way, essentially.
Yeah, perfect. And that is published. You can see about it. You know, then we went into an instrumentation for a cut guide in order to do this equally and consistently. And, you know, this is what you're seeing here. Bret, we ended up treating the second and third metatarsal as one joint, and we found that more consistent. Talk to us about that process with the instrumentation.
Yeah, and so give you a little bit of the backstory. When we first published, Bob and Dan and Paul and I, our classification, we identified metatarsus adductus. At the time, though, we were just starting, we were learning, we were trying to figure out Lapiplasty, and we just didn't have the bandwidth to tackle metatarsus adductus. And so very quickly when we got to that point, this was one of the things, because I will tell you historically, I hated metatarsus adductus surgery. I stuck my head in the sand. I tried to ignore it. I would ship them to Pittsburgh, so DeCarbo would have to deal with it, whatever I had to do to get rid of them. And then once we developed the system, now it's one of my favorite procedures to do. They're some of my happiest patients. It's a life changer. You know, we published on this that we had over 2 centimeters of narrowing of the foot. That's massive when you think about shoe fit, especially with Adductus, because most shoes are not designed for that. That's a huge life changer for a patient. They can wear shoes that aren't Ronald McDonald shoes anymore. So, you know, it was really happy to kind of develop this. And one of the things we noticed was we wanted to keep the second and third unit together. That central column should be contained as one unit. And that's one of the reasons why we focused very much on not taking anything down between 2 and 3. The only area that you need to focus on and release, and I know we're talking about some pearls and tips here, and I tell this to my residents all the time, is if you look at any one case that you're doing, I don't care what case it is, there are 3 to 5 key steps. If you get those right, you're probably going to have success. This is one of them, keeping the central ray and central column units together, but releasing between 3 and 4. That 3 and 4 release is absolutely critical because you need to swing not just the quote unquote IM angle, if you want to call it that. I know it's not really because it's a wedge osteotomy you've made, but taking that, but not just taking it lateral, but lateral and rotationally upward. It's got to be a 3-dimensional movement that you do to close that down. And if you keep that sort of connection between 2 and 3, it makes that so much easier to close that sort of osteotomy and have it aligned properly for good fusion.
Yep, and we'll show video of that technique so that becomes a little more clear. So we can go to the next slide. So, Jody, talk.
I throw in there also, when you keep those 2 metatarsals together and you do that up and out technique and get that reduction, you keep the metatarsals all on the same plane together. So it keeps you from having to like set each metatarsal in place. Very challenging.
Excellent point. Very good point.
So Jody, this system over time, it's also developed for midfoot arthritis. It's also developed for a smaller incision, which we call micro adductoplasty or mini adductoplasty. Just talk about the instrumentation and what we're looking at here.
Yeah, so I mean, really basically what you're looking at is a combination of single and double cut guides that can take care of a 0-degree angle, whether you have just that midfoot arthritis like you alluded to, or if you have an angular deformity, as well as essential instruments to help facilitate identification of your joint, to decrease your incision size, and also to help with soft tissue breakdown and to oppose the bone surfaces when you're getting ready to put in your permanent fixation.
Perfect. We can go to the next slide. So Bret, everything we've tried to do was decrease morbidity of the patient early on. That was immediate protected weight bearing with our biplanar plating system. And then over time, we've tried to decrease incision size. So the evolution of Lapiplasty, the evolution of Adductoplasty, can you speak to us about what we're looking at here?
So one of the things that I've always focused on is, what's the incisions are incisions. And I get there's the whole MIS thing, which is great, and I'm glad that people are thinking about it. But pretty much every incision that we make is minimally invasive. It's the incision we need to do the surgery properly. But we felt early on, and I was kind of very focused on this with my development in this area, was how could I limit my soft tissue dissection? Because I realized that was a big part of postoperative swelling and discomfort for patients. And one of the things that would sometimes limit their activity with weight bearing, which I wanted them to be able to do right away. So as we realized, well, if we could take and improve our instrumentation to decrease that incision, we could help patients feel better quicker, get them on their feet sooner, and have less, scarring and adhesions and all that stuff. So simply over time, we've sort of gone through this process where we kept thinking, okay, well, we had this one version. And I remember the old picture we used to put in the talks years ago about iPhone. There's iPhone 1, there's iPhone 2, iPhone whatever we're on now, 67.5 extra max or whatever, I don't know. And so it was the idea of it was constant development, iteration of newer and improved and refined instrumentation. And the addition of instrumentation, things like the different, rhizotome, lapitome, the different plating systems, moving from sort of the traditional plate and screw to more of the speed plate idea. All these different things were simply ways for us to improve upon the efficiency and the outcomes, and also the patients having less scar, less swelling, less pain, less incision. So we just kept focusing on that, and it was just a sort of a process that every time we get together to do a lab, which was almost every month, try to get it better every time.
We can go on to the next. So the evolution of fixation really maintained the biplanar plating. Jody, we see at the end speed plates, and we're going to talk about that in greater detail. Talk to us about what the benefit of this, why this came about. You know, why did we evolve from plates and screws to a single structure monolithic speed plate?
Yeah, and you know, many of our users are probably still using the current locking plate system. So locking plate systems are not going away. These are still an excellent form of fixation. The patients do quite well with these. But migration to the speed plate, which, like Will said, is one unit, it's one piece. The benefit is fewer moving parts, and also the ability to provide dynamic compression through the arthrodesis site by pre-tensioning and pre-loading these implants, which are the same titanium 23 that you're going to find in the screws and in the plates of the S1, S2, S3, and S4s. You're going to find that same titanium in the speed plates. And just kind of trying to decrease the footprint, increase physician efficiency, and also help to provide consistent compression, which makes it so there's a little bit of forgiveness when you're doing that initial bone apposition at the time of initial correction.
Perfect. Next slide, please. So, Bret, talk to us about the different options. So you see the 3 steps: you drill it, you implant it, then you compress it. How does that work, and what are our options in regards to size and shape for these speed plates?
So the plates, like a lot of our sort of initial plating system, come in a variety of different sort of lengths and, we'll say, strengths, right? You've got the bridge, which is sort of the plate portion. It comes in a couple different thicknesses for the 4-hole versus the 2-hole plate. And then also you have your tine length, right? So how much purchased into the bone you're going to get. And then the one that was really, to me, and it's become one of my favorites, is the micro quad. We all wanted to get to a smaller incision, but we realized a 4-hole plate, you just needed more of an incision to get a 4-hole plate in, especially with a speed plate, because obviously you can't put the plate down, move your skin around to get other screws in like you could do with the traditional sort of plate and screw combination. This one, you had to put all 4 of the tines in at the same time. So it made for, you know, a little bit more challenge with making the incision appropriate. So we realized that the 2-hole plate was great, worked well, but maybe wasn't quite as rotationally stable for some of the more highly involved rotational deformities, especially Metatarsus adductus. And so we realized we needed the rotational stability, but we wanted a little bit smaller footprint, and that's where the micro quad came out. So those 2 little tabs you see on the end there, it seems kind of like, well, really, what are those doing? We were shocked. We had about a half a dozen iterations of variations of what is now currently the micro quad, and that was surprisingly unbelievably stable when we did it, and you got the nice small footprint you're looking for. So you're able to now mix and match all these different combinations for what your patient's anatomy needs. So we were trying to give folks the solutions to help them be able to accommodate different situations, especially when you're dealing with, in Metatarsus adductus, for instance, sometimes that middle cuneiform, a lot of cuneiform can be sort of not very much there. You don't have a whole lot of real estate, so you need something to go ahead and fixate in there. So maybe you can't put a traditional 4-hole, but you can maybe get a micro in there and still give you that stability.
Yeah, for sure. These are great. And then that kind of put us into our SpeedMTP. We added a couple of screws to this plate. So Jody, you're going to talk about a very unique case with a revision for this, but talk to us about the primary focus of this plate. Why was this developed, so to speak?
Yeah, so one of the things that we could see with motion and activation of a joint after the hardware has been placed is the speed plate, singular speed plate in across, like in this case, across the dorsal aspect of the joint. It could potentially shift or spit just because the motion can actually reactivate the plate to a degree. So what we came up with is this concept of applying out of plane locking screws, and this uses the fast pitch screw system to really kind of suck the plate down, hold it into position, and having the tines and the screws off axis from one another makes an unbelievably stable construct. Whereas we were doing biplanar plates before, and sometimes we still do a biplanar construct for the first MTP. I mean, we did that forever and it worked so unbelievably well. I found that we're able now to use a singular monolithic, speed plate with these 2 off-center screws, and these things are unbelievably strong, and it provides again that dynamic compression across the joint, which I think we do lose with more so the static plate screw constructs. And then there's also availability to put a crossing screw here at the joint to lock the bottom of the joint if you wanted that extra bit of security. I know that most of us grew up doing a crossing screw and a dorsal plate, so that should look very, very familiar. But just very anecdotally, we did do a study, an early preliminary study, a 6-month poster on this that we put out at ACFest this past year. And what we found was about half of the population in that study used the crossing screw and half of them didn't. And there really wasn't a difference in the arthrodesis rate or the maintenance of correction in the patients that were coming in with the arthritic hallux valgus deformity. So this has become my go-to construct right now. I use this in all the patients, and I've been really, really happy that I've made the switch.
Yeah, Bret, this has been a plate, and this technology has just been a game changer. What are you seeing with your patients with first MTP fusion using the SpeedMTP? And what would you say to somebody that hasn't tried this plate yet for this segment of bone?
So I love biplanar plating. Obviously, I've been doing it for quite a long time, but I will tell you, and I will sort of echo what Jody said, we were all raised on the same diet, right? Dorsal plate, crossing screw. And so it's something that most of us are very comfortable with, but now you get all the benefits of the stuff you liked, i.e. plates that can kind of adhere and stick down, but also now you get the compression with the speed plate, you get the crossing screw if you wanted. I mean, and that's this same idea that you see here with the sort of fast pitch screw that sort of sucks that plate right against the bone, super low profile. You're going to start to see this same technology applied in other areas from Treace, because it's such a wonderful concept. That combination of speed plating and fast pitch screws, instant compression and stability, it's fantastic stuff.
And the memory of that plate also, I mean, if there's any small bit of reabsorption that occurs across these arthrodesis sites, the plate adjusts in real time for it, and it continues to compress, which is like, it's the best. I mean, the joint stays together so well.
Yeah. So Bret, you just talked about, kind of expanding that technology, and, we want to introduce a SpeedTMT that is not full market release yet, but this is designed to be placed at the proximal at the TMT, and you can kind of see the curvature of this. Bret, talk through this. I mean, this is what we saw with excellent results with the SpeedMTP at the first metatarsal phalangeal joint, and then we extrapolated that technology to the tarsal metatarsal joint.
All right. So one of the things we were sensitive to was, again, the school lunch we all were raised on, right? Peanut butter and jelly. So thought, okay, well, is there a way we can talk about?
We have Isley's chipped ham in Pittsburgh. Nowhere else in the world.
Hermanni Brothers or something ridiculous that gives you heart disease. Who knows? So the idea was, could we give folks sort of that dorsal or dorsal, medial plate that was so commonly used for traditional Lapidus, but could we expand it in terms of what the technology offered us? And so we thought, well, could we take what we did at the first MTP with the SpeedMTP, use similar ideas? Obviously, shape-wise, we had to make it work more for the proximal TMT because the shapes are very different between the two areas. And then, is this something that would help us? And when we started working on this, it gave us the concept of, geez, we can get sort of people what they want if they're not totally in love with only biplanar plating. Could we give them the dorsal plate or dorsal medial plate, add and supplement maybe a micro quad or a two-hole plate, speed plate, or maybe even just a crossing screw. So all these things started to come into play. And we thought, well, what about applying the technology we've developed that's been so successful in one area and sort of seeing if we can apply it. And it's been awesome so far. We're working on targeting jigs for crossing screws to go along with this and supplement. So it's got a lot of fun stuff to come for sure.
Yeah, and this is going to be an enhancement of our biplanar construct at the first TMT. So super excited about this. We can go to the next slide. So Jody, orthobiologics is a big item and an often needed item in reconstructive foot and ankle surgery. Treace got into the game with sort of a injectable or moldable models as well as wedges. Can you speak to this in regards to when you use it and why you would use this?
Yeah, so I've primarily been using the MTP allograft wedges for revision cases. Where you have failed hardware, where you need to do a takedown of that joint, and you're going to lose bone stock, and you don't want to end up with a very short hallux. So these wedges fit so nicely at the MTP, and they are made in a way that they will fit with your cup and cone reamers. So the concavity and the convexity of the wedge will match the use of the reamers at the phalanx and the remnant metatarsal. There's multiple sizes. There's a 5, a 9, and a 14. I've used these very, very much. These are like my favorite. And I often couple them with autograft as well, kind of pack autograft around them. But I've also had several failed Lapidus, traditional style takedowns where I'd have to go back, resect bone, and I need length again. And so, there's some places where non-structural bone graft just isn't going to give you that security of having that spacer essentially in there that's going to over time get replaced via creeping substitution. But you really do need that span initially. We use these for Evans. Evans works great several times. But if you're looking for some type of cortical fiber, something that's moldable, and you're just doing a primary, arthrodesis, whether it be subtalar joint, talonavicular joint, midfoot, or elsewhere, take that product. You can even mix it with blood, BMAC, PRP, what have you, and you can just fit that into some of these recesses and areas, especially where the patients have bone cysts or other changes. So this has been great for me because it also makes it so that when my Treace rep comes in the room, they have everything that I need, and I'm not calling anyone else in to come and help with the case.
Yeah, super important. We'll talk about our FastGrafter as well. So we still have autograft, and this is allograft. And Bret, allograft from the literature has been very positive in regards to reconstructive surgery. You're implementing this in your practice as well?
I would say for me that it's almost whenever possible, there is some component of allograft as an enhancer, but autograft is the primary for me. So I love allograft. I think it's great stuff, but I always love to grab some of the patient's own tissue. I mean, why would we not? And that's exactly what I tell my patients. I'm like, hey, I'm going to do this for you, especially for all my midfoot fusions and stuff. I'm going to add autograft for sure. The literature very much supports that. And so I tell them, look, I'm going to use you to help you. Like, why would we not do that? There's really no downside to that, right? Like, I'm going to take your tissue, which is the best tissue in the world for you, and I'm going to get some of it. Now, if I need a little bit more, the allograft stuff is fantastic, especially obviously, as Jody just mentioned, with the wedges, when you have distances and different things you have to work with, that's very, very different. But for primary stuff, they're always getting autograft from me for most of my midfoot primaries, any revisions for sure. And then as a supplement, I'm always usually using the allograft as a bulk enhancer to kind of help that component for sure, with more of the cortifuse versus wedges are obviously more structural components, or at least space enhancing performance devices. So
for sure. We can go to the next slide. So one of the things that's interesting with Treace, we pride ourselves on being an all bunion company, an all solution company, and we developed a system for minimally invasive surgery, or MIS, both with a plate and with 2-screw fixation. Bret, early on back in 2014-15, when Lapiplasty was coming around, we actually had a triplane osteotomy that we've patented, but we just couldn't get the instrumentation and it dialed in consistently. You want to speak to that? So this is something that has been on our radar. We've been thinking about and talking about and working on for well over a decade.
Yeah, I mean, so in our original paper and discussion and classification, we had osteotomy as one of the options if considered in a triplane fashion. And very early in our earliest labs, this is pre-Lapiplasty being even launched, we had worked on a both scarfplasty and a base opening wedge triplane correction. What we realized was there was so much inconsistency at that time with our instrumentation. And I think it's not that it wouldn't have necessarily worked. I just don't think, and this is our failure as designers, was we just weren't there yet mentally understanding how to help osteotomy correction in 3 dimensions. Flash forward now, almost 12 years later, it's different. We're in a very different place. We've had thousands of hours of working on this, thousands, hundreds of thousands of cases to give us feedback, and lots of our surgeon community giving us feedback. And so it started to make more sense to consider revisiting that, and I'm glad we did. We have a phenomenal MIS advisory board team, some of the just greatest folks who have really helped, and I give them all the credit, making this concept that we sort of kind of thought of the 3-dimensional thing and transitioning it to people that were way smarter than I was to make osteotomy 3-dimensional corrections work. So they took the principles and they applied it in the world that they were experts at, and thank goodness. I can tell you I could have never done what they've done with this, for sure.
But Jody, 2 concepts. We have the intermedullary plate, which is about a 1.5 centimeter incision, and then true percutaneous with stab incisions with the percuplasty. Can you just briefly talk about what's the difference between these 2 MIS options?
Yeah, so Treace provides, one of really the only 3-dimensional intramedullary fixation device and correction through that 1.5 centimeter incision. They do away with issues that most of these implant companies are coming out with the metal bunion, right? So they deal with that problem there very well, and these things are extraordinarily low profile and extraordinarily stable. In contrast, the percuplasty really answers the question of how do I consistently throw the single or double screw fixation through that long throw from that proximal aspect of the metatarsal shaft into the head, hitting that accurately and maintaining that stability without that frustration of trying to come back over and over and over again, trying to do this in a free-handed method. So both of these systems answer 2 of the biggest problems with the current devices out there on the market.
Yeah, for sure. The triplane correction is really what we're striving for. And whether that's triplane at the first tarsal metatarsal joint or triplane with the distal osteotomy, we're doing this with instrumentation in order to get consistency, take out the human error, and then, as we've shown, best-in-class fixation for immediate protective weight bearing. So this has rounded out our portfolio and our options for really a comprehensive bunion correction company. We can go to the next slide. So, Bret, talk to us about this algorithm and family of procedures. We'll actually show the algorithm in a minute, but what are we looking at here as far as options for midfoot and forefoot deformity when patients come to the office?
Right. So early on, when we looked at the kind of defining our classification and bunion algorithm, we thought about the differences that we saw in the different bunion types, we'll say. So when we looked at it, we said, well, there's bunions, there's bunions with rotation, bunions without rotation. There's Metatarsus adductus. There's also bunions with degenerative changes at the MTP. Sometimes there's all of those things. You have metaductus, degenerative changes at the MTP. So you got all these different things. So what we started to look at was, well, what procedures should we do? Which procedure instrumentation system works best for these specific things? So the algorithm kind of breaks down. If you have, this, go down this pathway. If you have this, go down this pathway. And the idea was to come up with a complete portfolio of solutions to address each thing. And then, and again, a lot of credit to Treace and the support of our research is taking and looking at the outcomes and results of these procedures to make sure, did we do what we wanted to do in terms of correction, and did we get the patient outcomes we are hoping for our patients and for us? And
go ahead, Brett.
No, like for instance, and Will and I, we were co-fellows together. So Will and I have known each other for a million years now. And, if you had done a double or a quad, which we now do routinely, that was heresy back 20 plus years ago, right? He would have never done those procedures. Oh gosh, the person will never walk again. And I give a ton of credit to Will because he's collected a tremendous amount of data on these. Like, these patients do fantastic. And so what was taught to us years ago as heresy to do these, procedures that you can't fuse the TMT and the MTP. Oh my gosh, you definitely can't fuse TMT, MTP, and the lesser TMTs. We now know actually these people do fantastic. So
yeah, we have multiple outcome studies that prove that. So it's been really successful. Then go to the next slide, please.
Also, not just radiographic outcome studies, but rather patient-reported outcome studies, kind of assessing
I'm
their
sorry,
own.
I thought the algorithm was next. I apologize, Lauren.
Yeah, no, excellent point, Jody. These were outcome return to activity studies, return to sports studies. Like these were not like, look, radiographic studies, fine. I personally, whatever. They are what they are. That's just, honestly, that's the surgeon patting themselves on the back. Look at that correction. Wow. I want to know how the patient did. That's what truly matters at the end of the day. Did they get back to what they want to do? Did they get back to doing the activities they enjoy? That's what really matters. Us patting ourselves on the back about a good x-ray is not valuable in my mind.
Yeah, so this is the procedure algorithm I wanted to get to that shows that family of procedures. So Jody, a patient comes into the office, has hallux valgus. There's really two lines that they can follow. Can you talk to us about this algorithm? What are we looking at? How's this work? And how is this applicable to what Brett was saying, that we can plug in one of our treatment options for these patients?
Yeah, patients walk in and I'm assessing to see radiographically, do they have osteoarthritis of the first metatarsal phalangeal joint? Yes, no. And also, do they have any presence of metatarsus adductus? Yes, no. And then from that, I make my decision. Do I need an MTP fusion? Do I need a double? Do I need a quad? Do I need a straight up Lapiplasty or a 3-2-1? Again, it's based upon joint health and lesser metatarsal position. After you have that, you basically have an entire cross-section of procedures that can be performed for those patients.
So what's next? Treace is constantly working on things and constantly trying to get better in regards to outcome and patient satisfaction. You can see a whole kind of plethora of midfoot and forefoot deformities, whether it be previous failed surgery or primary surgeries, just with a very difficult case. So Brett, we talk about something called patient-specific instrumentation. So talk to us about what this is and how it is used and developed with Treace and our patients.
So I think a lot of us are familiar with PSI, with joint replacement, ankles. I mean, I can't even imagine anymore doing a non-PSI total ankle. And so basically the same concepts now moving to midfoot, forefoot deformity correction. And this has been an absolute game changer. I had a patient the other day, had very severe cavovarus deformity, young kid, and I did the case using PSI to help guide me because he had severe metatarsus adductus with his cavovarus. And I have never had a case go like that where it was so smooth. My correction, I was like, this is crazy. So what I can do is now I can virtually plan how can I correct this deformity before I even go to the OR. So one of our mantras in Treace is always correct before you cut. Still the same concept. It's not changed one bit, but we're virtually correcting before we make our cuts. And it's just like a PSI for a total ankle. You go through a whole planning session with the engineers, make sure you dial in the correction that you want, tweak this, tweak that to make it what you need it to be. And then you get custom PSI guides that are referenced off of the bone from the imaging studies that you sent. And it was just, I mean, this is a game-changing procedure for me, especially for people who have either severe deformities or need revision procedures of old failed stuff. This is going to change all of our lives moving forward. And I think it's going to impact us in all kinds of parts of bone surgery, whether it be in our world of foot and ankle or other parts of the body with orthopedics, knees and hips and shoulders and stuff. This is the future of where we're going.
Yeah, so really exciting. And this is a case just kind of walking through the pre-op planning. Just like Bret said, you can do virtual surgery or CAD surgery. So once you get the weight-bearing x-ray and CT scan, ideally weight-bearing, but non-weight bearing works as well. They can make these guides specifically the patient to dial in the correction. So instead of, say for Adductus, instead of 6-degree cut guide, you can get a 7.2 if that's what you needed for the patient. Same with the first TMT. So we're super excited about this. And this is technology that is available as of now. We can go to the next slide. I think we're getting into cases. So we want to kind of highlight some of this. So what's important in regards to the setup for all these procedures is x-ray. An x-ray is something that if you understand the x-ray, you understand Lapiplasty and Treace procedures. When we look at the AP x-ray, we're kind of teasing that into two separate x-rays. One is a full weight bearing where you can focus on the metatarsal phalangeal joint, the sesamoids, the lateral round sign. That's all the way to the left. The center picture is what we call Treace AP, and that is looking down the joints and looking down the cut guide. We'll explain this a little more later. Usually it's anywhere from 15 to 20 to 30 degrees of dorsiflexion off of the plate. So the beam shoots down the joints, and then we have a lateral x-ray. We can go to the next slide. So Jody, when we're setting up this x-ray, and we're putting in our system for the 3-in-1, what are we looking for to ensure that we have appropriate alignment?
Yeah, we want to see that the joint is being captured by the cut guide in its totality, and you're looking for those perfect circles at the proximal and distal most aspect of the cut guide. Those are nice and round and very visible, and we're also looking for that seeker in the center of that cut guide to be like a sliver. So those are the key things for the cut guide setup, as well as making sure that our position is appropriate. Our first metatarsal is parallel to the second. Our joint is congruous and our sesamoid alignment has been brought back. We're looking also that we're making appropriate cuts off the metatarsal base and the cuneiform, and that we're going to actually capture the bone that we want to cut so that we can get the correction that we've intended.
Yeah, and these are slides here that cannot be overstated. If you understand these three pictures in this specific slide, by and large, you understand Lapiplasty. So when Jody's saying about capturing that sliver, that speaks to the sagittal plane correction and alignment. If you have the correct sagittal plane alignment on the x-ray, you'll see the sliver. If you have the correct frontal plane, supination, pronation, you'll have the open, gun sight, so to speak. And then if you have the correct cuts on the metatarsal base and the cuneiform, then you have the correct sagittal, transverse plane alignment. So it's showing all three. And then Bret, once we have that alignment, what are we looking for? There's 4 main points for reduction. And what are we looking for on that slide all the way to the right?
So obviously the key components are the round sign. So that's your rotational component that you're really double checking. So when you see that lateral round sign, that's essentially the plantar aspect of the metatarsal head. So it should be very straight, almost. Sometimes it's like it's not only straight, but there's like a little tiny beak you can sometimes see. at the metatarsal articulation there. And then obviously you want to see your sesamoids reduced, and you know that's kind of our goal. And depending on which type you have, rotation or rotation with subluxation, you got to be careful, because you could have it rotated properly but still not see the sesamoid reduction if you haven't done a good release yet. So again, think about those things. If you're saying, geez, that lateral round sign's gone, it looks really good, but my sesamoids don't look so great. Okay, think about going back to your lateral release. Did you get it all the way? That's where I will tell you my failures when I have not gotten it perfectly. It's always at my distal release. That's at 95% of the time. Obviously, you want your joint aligned. You don't want to go into varus, which is very rare unless you were to do something and overcorrect. Obviously, you also want to look at your cortical changes. You want your cortices to be fairly symmetrical in your metatarsal, and of course, IM angle is closed down to where you want it to be. And so all those things you need to be looking at to make sure, am I seeing what I'm seeing? Am I truly seeing it? And also be careful with your rotation. If you rotate the foot to kind of correct it better on X-ray, are you really correcting it better in real life? Or is it just an X-ray correction that then is going to be a quote unquote recurrence because it was undercorrected on the table?
Yeah, so important to understand this X-ray, and we do these educational conferences all over the country with cadaver labs. It's great to get your hands on this. So we'll go to the next slide, go through some cases quickly. So Jody, the same alignment that's important for Lapiplasty is important for Adductoplasty. You know, the alignment medial and lateral for this guide is critical. Can you just discuss that real quick?
Yeah, so when we shoot the X-rays to make that determination, we're shooting an oblique image, but we're shooting almost a gun sight view down the second and then down the third tarsal metatarsal joint, again, making sure that we're capturing all components of those joint spaces and not overlapping the adjacent bone. We want to cut what's within the auspices of the guide. We don't want to cut the adjacent bone anatomy.
Perfect. And then we'll go to the next. The up and out, the video to the left is what Bret and Jody were talking about earlier. So once that bone is evacuated, this is what the triplane correction is. It's not pure transverse. It's an up and out correction. And then we're doing temporary fixation on the lateral side of the third tarsal metatarsal with the compressor, and then a threaded olive wire crossing the second metatarsal phalangeal joint. So what this allows you to do with this temporary fixation is assess your correction. And if you have a negative plumb line at this point, you're ready to fixate. If you still have a positive plumb line, you can do what's called a double cut, take a little more out of the central metatarsals by putting the guide back on, pinning it, and cutting just the metatarsal side. We can go to the next slide. So Jody, this is your case that a patient comes in with metatarsal adductus. You just want to talk about this for us?
Yeah, so the question often we get asked is, you know, why are we fusing healthy joints and why are we reducing these lesser metatarsals? You know, can't we just do something in isolation at the first? You know, the problem is these patients have painful deformities. They have lateral deviation. I mean, these are gross deformities of the foot with a mismatch between the width of the forefoot and the hind foot. And they end up also with lesser metatarsal pain. And to correct this first ray in isolation, you'd end up trying to induce some type of negative intermetatarsal angle. So, you know, what other options do we really have? So the argument's been made, you know, why are you fusing a healthy joint? Well, my argument to you, Will, and anyone else that would say that is, well, these are not healthy joints. These patients have a significant deformity. It's congenital in nature. It progresses at the first ray over time. And so we can resolve all of these issues through a correction of the deformity at the apex.
Yeah, and I think it's super important. You know, this first tarsal metatarsal joint is a unifacet. Multiple studies on that. Patients in bunion, greater than 80% of the time, have a unifacet. Upwards of another 5 or 10% of that is a bifacet. The only stability in non-diseased joint is a trifacet. So these are not anatomically normal joints, they're pathologic. So we can go to the next slide. So this is our first TMT system. We try to break it down in the steps, and basically there's 5. So we have cup and comb reamers. that are in the set, and that's part of the taking down of the joint. You can see the guide mimics the plate over top, same as the speed plates. We have a targeting device for the inner frag screw. That way we're not hitting the inner tines. That's step 3. And then we insert the plate with the off-axis screws and then energize it. You can see the compression, at the end of this. It's just been fantastic. And we have, 1-year data now that we presented at ACFAS, and then this will be turned into a paper. So this is the main construct, is this dorsal locking plate with screws. The next case is Jody's, and it talks about a revision. So Jody, you did this case in a unique way with the SpeedMTP. So you want to go through this?
Yeah, so we had a pretty large patient come in, and so the patient had 2 prior surgeries. Relatively healthy guy, no real significant past medical history, but he told us that he had come in and he had a Cartiva put into the joint in 2016, which unfortunately had failed him. And then the patient went on to see another surgeon, and they had an attempted first metatarsal phalangeal joint arthrodesis. He said the Cartiva, when the other physician got in there, he said that it essentially had dissolved or was no longer present within the joint, and the patient had significant joint detritus and other issues. So he had this issue now where they fused the toe in an elevated position, and the patient's primary concern was, 1, motion at the fusion site, but 2, the second digit was constantly underlapping the hallux, because the second digit no longer had the book-ended abutment of the great toe to kind of keep that second digit from drifting. So you can kind of see that there on the lateral. And so intraoperatively, the image on the left, we took the plate out. You can see the significant amount of holes that were in the bone from the previous locking construct. And then on the right, I drew the axis of the proximal phalanx, and I drew the axis of the metatarsal for the purposes of trying to, provide an understanding of how elevated that hallux truly was. The pin that's placed there is within the old joint, what's left of the old joint there. So we placed that for, again, a point of reference, the apex of where the joint was, and then we started to take the joint down moving forward. And lo and behold, when we got into the joint, we found that the Cartiva that was supposedly dissolved was not dissolved, but it was just an in situ fusion of the Cartiva in the joint. And this was also a large reason for why this also failed, because this wasn't addressed. So we cup and cone reamed this, took the bone down at the proximal phalanx, which had really good remaining bone. Then we tried to reshape and remodel the metatarsal remnant by taking an access wire, sliding it up the central aspect of the metatarsal where that Cartiva was, reaming this, and then we also significantly debrided and fenestrated the hole in which the Cartiva previously resided. And you can see that there as well. We used autologous bone graft, packed the defect, and you can see right here this this actually I think was a 9mm first MTP cortical wedge that was placed into the joint to fill up that space and reestablish length of the hallux. And you can see how nicely that fits with that cup and cone construct as we were talking about before. And then we said, okay, well, let's get this fixated. Now, this is a rather large individual, and so we used a large SpeedMTP ×2. So we got the first one in a dorsal medial position, got the other one in a more lateral semi-dorsal position in a 90-90 construct, spanning that bone graft, and to provide that internal external fixator type effect like Bret was talking about with those locking screws, tying this thing up extraordinarily stable, and then packing the remainder of the defect with autologous bone graft, and then closing the patient up. And this guy now is about a year plus out, and he is doing really, really well. You can see the toe is nice and straight. It's no longer elevated. And we did not have to do any work for that second digit now that all the toes are aligned. So the caveat here that I would tell everyone is when you're setting your hallux position, the pulp of the toe should be in contact with the ground. and we don't want to have that elevation of the hallux up off the floor, because you end up in these situations. And I like to say that this is an isolated type case, but we do lots of revisions for these types of problems for these patients that seek help after bad positional fusions. But this application of a biplanar SpeedMTP, will I get to do this again? Maybe at some point, but again, this guy was pretty big, and he accepted this hardware well. But just speaking to the versatility of the Treace system and the ability to not just do the primary cases, but the more difficult revision cases.
Yeah, no, great save, great case. We'll go on to the next slide. So these are just examples with the Speed TMT, so you can see that in a biplanar construct at the dorsal lateral position, whether it be primary bunion, and then the case all the way to the right is a quad, and you can just see the versatility of this plate. So super excited about this. Again, this will be full market release coming shortly. It's currently in limited market release. We have a sterile pack instruments. All of these instruments were purposely developed in order to make the procedures more efficient, whether it be Lapiplasty, Adductoplasty, SpeedMTP, Nanoplasty. So you're seeing rafts and bone grafts and releases and osteotomes. Two of the things that I'd like to call out specifically, the feather raft all the way to the left. This has been a game changer for all reconstructive surgery, foot and ankle. It smooths down the bone. This fits onto like a striker handpiece. The idea of this is the speed plate technology is one monolithic structure, and it has to go in with the 4 tines all at once. So if there's any underlying bony exostosis, we smooth that down. So that is the feather raft. It works amazingly. The other that I want to point out is the achinator. So we have a single blade for the Aiken osteotomy, and it comes in a transverse orientation, where if you want to put your wedge medially based, and it also comes in a dorsal based osteotomy and fixation with the Speed Aiken. So this has just been a game changer in regard to our release tools and our rafts. And then in the center is the FastGraft there. That's autogenous bone graft. This is something we can get out of the calcaneus or the distal tibia. Very quick, easy, and we're able to get anywhere from 2 to 5+ cc's of bone very readily, and that helps with augment these fusions. So this is just more of our procedure. This is an overall view of our portfolio. This is not a complete picture of it, but it just shows, we have multiple different screws and sizes, headed screws, fully threaded screws, lag screws, twist off screws, hammer toe implants. So Treace is really focused on developing a system where you as the surgeon can go into a case with pathology of midfoot, forefoot, and have all bases covered, from fixation, instrumentated correction, as well as biologics, in order to get the case completed at a very high level. So the last slide, Jody, you want to talk about the SuperByte compression? This is up and coming. We're super excited about this. So you want to talk about this?
Yeah, so SuperByte, you're going to see multiple sizes. So this is Treace's kind of movement towards the hindfoot. So these can be applied for talonavicular joint fusions, subtalar joint fusions. You can use them for fifth metatarsal Jones fractures even, and anywhere else that you need a durable variable pitch screw that's going to provide excellent compression. The images up on the right with the screw moving through the bone block example is just basically showing how many of the commercial screws that are on the market currently, as the screw is entering into the bone, bore the bone out, which makes a channel which diminishes thread engagement, and where the current SuperByte system with its consistent thread pitch and consistent compressive thread pitch provides little of that. So you maintain a large segment of your bone volume as these are going in. So they go in very well, they bite very well, and they also provide excellent compression across those arthrodesis sites. So really exciting. self-drilling, self-tapping, cutting tip. And they have all the screws have a beveled head, similar to like an MIS screw, with the exception of the 7.0, which needs that larger, more robust, rounded head there. So again, all headless system, but really, really nice.
Yeah, Brett, have you had a chance to use these yet? I know they're just out.
Yeah, no, I actually had a case booked and it got changed the last minute, but I obviously play with them in the lab a ton. They are awesome.
So one of the concepts of this is, again, as we get into midfoot arthritis and midfoot fusions and flat foot reconstruction with concomitant patients have bunions and whatnot, we want to have a whole portfolio where you have options for those hindfoot, midfoot fusions. And these screws, once you get your hands on them, they are best in class for sure. So a couple of things we're excited about and we presented tonight: the SpeedTMT, the SuperByte, and then our legacy systems as far as Lapiplasty, Adductoplasty, SpeedMTP, Nanoplasty, Percuplasty. So exciting times with midfoot, forefoot deformity, and now even hindfoot deformity with options from Treace. With that, we'll open it up to any questions. If anybody has any questions, we're happy to field that at this time.
Yeah, please type in anything as we're waiting to see if anything comes in. Guys, thank you so much as always. These are always really fun for us. We enjoy them. I won't speak for the three of you. I know I enjoy doing these. And I also would like to do a plug for not only the surgeon webinars like what we just did this evening, but I'll open it to you in a second, but we do a number of peer-to-peer event and discussions throughout the week where if you have a case that you would like to review ahead of time preoperatively or discuss postoperatively, really in anything in between there, you can have a peer-to-peer consultation arranged with any of our faculty surgeons through our medical education department. So I highly encourage you take advantage of that. Reach out to your local sales representative or the medical education department at Treace. I'll open it to the three of you to maybe talk a little bit more on the effectiveness of that, but I can't speak to that offering of Treace Medical enough.
Yeah, I mean, it gives an opportunity to have one-on-one time with surgeons that are interested in learning more about the system, and also troubleshooting things that can come up that we've all seen. We've all been through it. We've all kind of had our own struggles and things that we hopefully, have come to a point now where we can really give some significant insight based upon our collective experience. I always find these things to be, I get a lot out of just the conversations with the docs, and hopefully they do also.
You're welcome, Jody.
Yeah, thank you.
A lot out of my conversations with you.
I mean, it's almost daily with Jody. We have to deal with this. So yeah, I get it. So yeah.
It's primarily me.
Yeah. No,
one of the things
we all reach and lean on each other, and I lean on, my former mentors. I'll ask questions and reach out to them. I mean, we all could use some time to just think about some stuff sometime and maybe bounce things or ideas off of somebody else. Just get, a different perspective, and it can help a ton. I mean, I love it. Just like Jody said, I learn a ton when I interact with one of the surgeons with, concern that they're having. I learn stuff. So it's great all around.
Yeah, and one of the things as a company that we really strive to do is, we're all in this together for patient outcome and success for the surgeon, success obviously for the patient. And so this isn't, hey, we have these products, we have these techniques, we have these systems, just go use it. We're with you throughout that journey. We'll talk to you pre-op. Most of the time we'll talk to you inter-op if there's a problem. We've had text messages from the rep. We've even had phone calls from the rep in the room. And then obviously post-op to digest the cases, what went well, what there was a sticking point on. So the education process that Treace provides is really second to none. And, this is a team and it becomes a family. So, we want you part of that with our procedures.
Yeah, agreed. And not only the peer-to-peers, but we have a number, it was mentioned early on, our medical education hands-on events that we have throughout the year. So please take advantage of those if you're interested in attending one. If it's been a while since you've been to one of ours, please get with your local rep or the medical education department and come and attend those. We have a ton of them scheduled throughout the year, and we are really excited. Dr. DeCarbo, Dr. McAleer, Dr. Smith, thank you so much. It was great having the OGs on. Thank you so much for being here. Thank you to those attendees.
Thanks, everybody. Have a great night.
Thank you.